So the demographics is changing. The younger people are developing heart disease.
So the youngest patient you've ever treated?
28.
And what was the predicament in that case?
He was having a full-blown heart attack. So that means that one of his arteries was completely clogged up. It had a blood clot in it. There was no circulation past that artery, and therefore he was having acute chest pain, sweating, blood pressure was low. He comes straight to the hospital. I rushed to the hospital, take him straight into the cath lab, and tried to open up that blockage. And we did open up that blockage and put a stent in it and got rid of that blockage immediately to restore that blood flow to the heart muscle.
And at 28, how does one get a heart attack? You said it was blocked up.
There's a lot of nuance in that. Most people don't understand what a heart attack is. So in a nutshell, I'm going to tell you what it is. When you have a plaque is a buildup of a little fibrous material inside the artery, and that doesn't cause a heart attack. A heart attack is caused when one of those plaques cracks. Now in this diagram, for example, it's showing that the plaque is closing up the artery, and this will cause angina. That means a lack of blood supply over here. So this patient may complain of chest discomfort, or he may not complain of chest discomfort. Because remember, when you have a blockage like this, only 20% of the patients actually get chest pain. That means that you could have a blockage like this in a patient, and he may not have any chest discomfort. And the only way you're going to pick that up is by doing a stress test or a coronary calcium score or some other modality to see whether he has blockage or not. A heart attack is when a minor blockage, which is not causing much flow disturbance, suddenly cracks.
And what happens to the plaque that cracks off?
And when it cracks open, the blood that's going past it sees the crack and wants to repair it and forms a blood clot on it. So the final thing that shuts down that artery is the blood clot. It's not the plaque that shuts it off, it's a blood clot. So a heart attack is caused by a blood clot at the site of a rupture. And what causes rupture is inflammation.
Okay, so when people say that heart disease is the #1 killer of people generally that are diseased, is it that process that's causing it alone, or is there a multitude of processes that lead to heart disease?
There's a multitude of things that lead to heart disease. Look,
so that was a heart attack.
Yeah, that's right.
Okay.
So, one, you're making plaque. You shouldn't be making plaque. A plaque is an inflammatory area inside your arteries. It's reacting to something. And I can go into the nuance of what's the body reacting to? What's inflammation? Inflammation is reacting to something. What is that something? And I think it's important for your audience and everybody to know what that something is. Now, you've got this pimple. Think of it as a pimple on the inside of the artery. Now, one day, when there's enough inflammation in your body systemically, that pimple is going to crack open, just like a pimple on the skin breaks open. Now that artery has this little pimple on the inside, it cracks open and a blood clot forms on it, and that's a heart attack. So you don't want plaque formation, you don't want plaque instability, which is rupture of that plaque, and you don't want a blood clot to form on it. There are factors that affect each of these processes, and all three processes are going wrong today. And that's why we have so much plaque formation and instability of the plaque, which then leads, of course, to heart attacks. And our blood, in general, we have more coagulation issues today than we ever did before, which means our blood, because of inflammation, is more ready to clot more easily. So we're having the perfect triad. It's the perfect storm. That's why we're seeing an epidemic of this, and that's why we're not making a dent in it. Yes, you can have a plaque rupture and have a heart attack, and we'll put a stent in you. Okay, that's fine. But what did we do to look at the underlying reason as to why you formed that plaque, and why did you rupture it, and why was your blood so clotty in the first place that made you actually seal off the artery?
Is this an increasing problem?
Yes, it's a huge problem, because those factors have been identified now, and that's what we go for in my practice. We look for the factors. Why did you make this plaque? Why is there so much inflammation in your body? Inflammation is a reaction to something foreign. What is that foreign stuff? What physiology in you that your body is reacting against, because that's what inflammation is. And inflammation, of course, whenever there's going to be inflammation, there's going to be increased tendency to make blood clots. So we go in, we chase all these things in patients to find out. And that's the real prevention.
That 28-year-old that came in and you treated him, was that a surgery you did?
We call it a surgery, but it's not. It's a angioplasty. So we're going from the wrist, or we're going from the groin with a catheter. And we go into the coronary artery.
A catheter being like a tube?
It's a hollow tube. And we put it into the coronary artery. We shoot the dye inside. We can see where the blockage is. And then we thread a tiny wire into that artery through the blockage. And then bring in a balloon and squash the blood clot out of the way. Restore the circulation. And then bring in a stent. A stent is like a spring that opens the artery up. We leave the stent inside there. We remove everything else. And now you have an open artery. And you have blood flow going down that artery.
And what had that 28-year-old done to end up in your surgery? What were the decisions that they had made that brought them there?
So he was, number one, he was overweight. But he wasn't just overweight. The overweight was all in his belly. And he had a fatty liver. And he had what is known as visceral fat. He was not a diabetic, but he was a pre-diabetic. That means he had a lot of insulin in his body. And his glucose levels were good. So if you went to his family doctor, they'll say, oh, you're not a diabetic. Your hemoglobin A1C, which is a blood test that you do for diabetes, is actually okay. But actually that patient had a very high insulin blood level. Now, insulin is a very atherogenic molecule. It causes smooth muscle proliferation. Smooth muscle is in the walls of the arteries. It causes vasoconstriction. It makes your blood more clotty. And it causes inflammation. So this patient was a pre-diabetic. And this is very important. This is what caught my attention. Because when I looked at my patients that were coming in with heart attacks and hardening of the arteries, and when I tried to identify why they're doing this, none of them were diabetics. But then I did a glucose tolerance test on them. And what happened, it was just by chance. But I happened to have these tests in my office where you can measure the blood glucose. So I had about 120 of them. So I said, look, let's just do some random testing on these patients. And I found that at least half of them had no diabetes, but their glucose intolerance. That means that the sugars went up, but not enough to make them a diabetic. But it did go above the normal range. We did not have insulin testing at that time. About 10 years later, we started testing insulin in the office, and I bought a machine for this purpose in my office to measure insulin levels. And life was never the same again.
Why?
Because it's all about insulin when it comes to the metabolic derangement. So I found that these patients, the sugars were going up to 150, 160 after giving them a glucose drink. So you say, okay, he's not a diabetic. Look, the sugar doesn't really go high. But when you measured the insulin level, the insulin was off the roof.
So when you say this is an insulin problem, can you explain this to me like I have no idea what glucose and insulin are? For any of my listeners out there that have an inexperienced understanding of these terms and what they do and mean.
It's crucial. Everybody needs to understand the relationship between sugar, which is glucose, and insulin. When you consume sugar or glucose, the body has to get rid of that glucose very quickly from the bloodstream, because glucose actually is toxic inside the bloodstream. Even though it is what the body uses for energy, in the bloodstream, it glycates all the blood vessels and the walls and the components in blood, and the hemoglobin as well glycates it. That means the glucose attaches itself to that molecule. So now that molecule can't work properly. That is why the higher your blood glucose, all your chemicals don't work well. Your enzymes don't work well. Your hormones don't work well. Nothing works well, and you age prematurely because you're getting glycation. A glycated molecule can't work normally. It doesn't function normally. So when you consume the glucose has to come out of the bloodstream. And how does the body do it? It sends a message to the pancreas. The pancreas says, aha, I'll make some insulin. It pours insulin into the bloodstream. Insulin comes into the bloodstream, pushes the glucose into the cells, And where does it push in it? Into the liver, into the muscles, into every cell in the body. Insulin will push glucose out. Now, how much insulin is the question? If I'm eating every 3 hours, and I'm consuming glucose, or I'm consuming starchy foods, or I'm consuming carbohydrates. Now watch where I'm going with this, because you're already beginning to know where I'm going with this. I'm consuming glucose and carbs every 2-3 hours. I'm stimulating my pancreas. I'm stimulating my insulin. My insulin goes up, it comes down. But before it even gets a chance to come down, it goes up again. So the repeated consumption of, and frequent consumption of glucose is causing my insulin to stay high, because insulin stays a little bit longer in the bloodstream than the glucose. The glucose will come down in about 2 to 3 hours, but the insulin stays higher for about 4 hours. Now what happens is that you continue this lifestyle for a few years. Now the body, because these are hormones, will say, well, I'm going to need to make more insulin now. You become insulin resistant. Any hormone that stays in your body for a long time, the body becomes immune to it. So the next time I eat the sugar, I'm going to have to make more insulin to produce the same effect. That is called insulin resistance. So now you got this patient who's been eating carbs, sugar, processed foods. What does that mean, processed food? That means foods that are quickly absorbed into the bloodstream. Processed foods. These are products without fiber. So the absorption is very quick. So the poor pancreas has to react just like that. Produces a whole bunch of insulin. And then the frequent eating and the frequent consumption makes you insulin resistant. So now you produce a whole bunch of insulin in order to bring that sugar level down. So then you say, okay, well, it doesn't matter because the insulin is bringing the sugar level down. So what's the harm done? Because your A1C is still good, you're not diabetic. No, but it's that background high insulin that is destroying your metabolism. It's that high insulin level in the background. So insulin pushes glucose into the liver and you develop a fatty liver. It pushes the calories into production of new fats around your viscera. The viscera means in your belly, around your pancreas. You get visceral fat. Now this fat is produced from glucose. It's a different kind of fat. Look, if I gave you a high calorie diet right now, all sorts of foods, you put on weight everywhere, okay? But if I give you glucose, you put it on mostly in your stomach. And your stomach will protrude. And that's called visceral fat. It's on the inside. You can't pinch it. It's on the inside.
Around your organs.
Around the organs. This is very detrimental fat. And that's the epidemic that we have today.
And that's a direct result of eating, starchy, glucose, carbohydrates, which creates insulin, which creates this downstream effect on
wrong foods and eating too frequently.
Too frequently, okay.
Because remember, it's also the frequency of eating. Because before that insulin gets a chance to come down, you're already popping yourself with more food. And hence you develop insulin resistance. You get a very high insulin. It takes this much insulin now just to bring that sugar level down. And then the one day when you cannot control that sugar, now that sugar will go out and now your doctor will say you're a diabetic. But by that time, you've already had 10 years of hyperinsulinemia. So what happens if by the time you make a diagnosis of diabetes to say, well, now your sugar is really high. It is high because your body has not had the ability to keep it down. Why? Because even that high insulin could not keep your sugar level down. You became a diabetic. You lost that whole opportunity of prevention. It's those 10 years. Look, by the time you're a diabetic and you come and see Dr. J in his cardiac clinic, you already have coronary artery disease. Like that 28-year-old. The 28-year-old didn't have diabetes. He already has coronary artery disease. By the time you are diagnosed as having diabetes, you already have coronary artery disease. We have a great opportunity here to actually start screening these patients with insulin levels very early on. But most doctors don't have the ability or knowledge to do the insulin level testing. But it should be done.
In someone like me, I'm 33 years old now. When does the damage begin?
It starts right now. It starts right now. As soon as you're around 30, you're already starting to have trouble. You have to, but this is what I do. I look at that patient patient walking into my room, and if I see that he's got a belly sticking out, I already know he's probably got insulin resistance, because all the fat is in here. Because the fat that's in the stomach, sideways, he looks terrible. From the back, he looks great. His waist is increased. He doesn't have all the fat everywhere else in his body. That's the phenotype of somebody who has hyperinsulinemia. That same person goes on a cruise, he'll come back 5 to 10 pounds more because he's got so much insulin in his body. Insulin is a storage molecule. It puts everything away. And it's very hard for him to lose weight.
Why is it harder?
The only thing that will make you lose that fat very quickly is to change your diet, of course, but you have to do fasting. Because fasting brings your insulin level. See, this is where fasting comes in. So what does fasting do?
Do you mean fasting or a calorie deficit? Or is it the same thing in your view?
No, they're not the same thing. They are not the same thing. See, when you don't eat, your insulin levels come down because you're not stimulating your pancreas anymore. So you want to bring your insulin levels down. The best thing you can do in the world is to do fasting. Because there's no, look, if I just simply cut down on my calories, then there's a different physiology that's going to take place in the body. And when you fast, there's a totally different physiology. When you cut down on calories, the body senses that there's caloric deficit. The metabolic rate changes, actually slows down. And the body will start breaking down everything, muscles included. So you lose fat and you also lose muscles. On the other hand, when you're fasting, it's a different physiology. Fasting is, I've put on fat, now I'm going to take it out of the bank. Now the bank is going to be available for me to pull out my calories and use it now. And you start burning the fat. So in the first 12 hours of a fast, you take out all the glucose in the form of glycogen from your muscles and your liver. After 12 hours, you start pulling the fat out. And the first place the fat comes out of is going to be visceral fat. That is why fasting benefits you so much, because it gets rid of that worst fat, the fat that is very inflammatory. You see, if I did a biopsy of your visceral fat versus a biopsy of, let's say, a fat from on your buttock, two different types of fat. One is full of inflammatory molecules, the other one is not full of inflammatory molecules. One is producing interleukin 6 and tumor necrosis factor, and this other fat is not. These are two different fat storages. Visceral fat is very toxic, it's very inflammatory. And that is why patients who have visceral fat make all these molecules. So when I do the blood test, I see that, oh, you've got so much inflammation. You've got interleukin 6 is high, tumor necrosis factor is high, your CRP is running high. And one of the reasons for this is not just leaky gut and other things that I look at, but in your case, it is also because you have a lot of ectopic fat. Ectopic fat. Ectopic fat is, now we're realizing, is not just only around the liver and around your pancreas, it's also around your heart. So when we look at the coronary arteries and we see all those fat around the coronary arteries, you had a very nice diagram right there. And you can see that around each artery, there's that yellowness. That yellow is all plaque. Fat. There's fat around that, and it's plaque forming. It's plaque forming. It stimulates plaque. It's inflammatory. And now we can do CT scans that will actually detect how much inflammation is in the fat around the arteries as well. Ectopic fat is around the coronary arteries, it's in your liver and in your pancreas, and it is very inflammatory.
On this point of fasting, so if you have someone come to you and they have that physique where there's a bit more of that protruding belly fat, you said that fasting is a much better approach than just sort of a calorie restriction. I was looking at some studies that said research shows that calorie deficits of any kind can reduce visceral fat, but fasting will give it an edge because of the insulin sensitivity stuff that you talked about as well. What kind of fast should one be doing? Because there's so many different names for these fasts. People do these 40-day water fasts and they do intermittent fasting.
It's a great question. So there are many, many different types of fasting. Depending on your goal, on what you want for that particular patient. So if a patient is just simply looking to reduce his visceral fat, then I start with 12-12, which means 12 hours, you don't eat anything, you just drink liquids with no calories in it, and then it's only water, black tea, black coffee, green tea, no calories. 18-6. 18-6. And then that's one type of fasting. Now, if a patient is very overweight, a patient has diabetes, and your goal is to reverse the diabetes, the patient needs to lose 60 pounds, then those patients have a special type of need. For them, I will take them to a 48-hour fast once a week. Sometimes I'll go to a 3-day water fast every 9 days. Every 9 days, you will do OMAD. OMAD means 1 meal a day only, every day for 9 days. And then you're going to give me a 3-day water fast.
Is the same advice applicable to women? Because obviously they're contending with a variety of hormone fluctuations and estrogen, and I know that the female body responds differently to these kinds of stresses like fasts.
I've been asked that question so many times from patients as well. Most of the women can actually handle it. The only women that cannot are those who are trying to become pregnant, or they have, or they're already pregnant. I think that women are not that different when it comes to the fasting programs. So in my experience, I've been able to get women to fast. I just finished a fast on one lady just now for 72 days. 72 days. She was terribly overweight. She had diabetes, she had hypertension, she had hyperlipidemia, she was having hip replacements, knee replacements, joint problems, she had skin problems, and we fasted her for 72 days.
What did she have in those 72 days in terms of drinks, electrolytes, coffee? What was she?
Great question. So she would have black tea, black coffee, water. And in the water, once a day, I tell her to put some electrolytes in there. So there's an electrolyte called LMNT, or sometimes I just have to go buy some Celtic salt and put half a teaspoon in there, and once a day you take that. If you get cravings and you feel really, really hungry, take some MCT oil, a teaspoon, and put it in your water, and you can drink that as well.
I think it's worth saying that probably you shouldn't try this at home, ladies and gentlemen, because obviously medical supervision is critical here. But in the case of that lady, what was the before and after of that 72-day fast?
So, diabetes, gone. Blood pressure, normalized. Weight loss, tremendous weight loss. I think she lost about 55 or 60 pounds. Okay. And not only did she lose all that weight, yes, all that weight from her belly was gone, but even her face, under the arms. So when you lose weight in a fasting program, it's very different from losing weight when you are restricting calories. You actually retract your skin, so you get real changes in your entire body. These patients, I had one patient that fasted for 183 days under supervision. Okay, so he went from 400 pounds to 210 pounds. And when he walked into the office, you would not recognize that he's just lost all this weight, because he did not look like skin on top of bones and then having to have surgery to remove all that excess skin. Fasting is a totally different physiology. In fasting, the body is doing a whole lot of things that are very different, and we can go into the physiology of fasting, because that's fascinating. It's a physiology that has not been used by us. We've lost it. So one of the things about modern living, we have lost this physiology of fasting. First of all, why do we still have that physiology in us? It's because it's supposed to serve a purpose. Because we're supposed to be fasting and feasting. But now we're only feasting all the time, and we're not fasting. In order to go back to normal, you should be fasting. Fasting is supposed to be a normal part of your existence. That's the way you were designed. Not this modern industrialized living that we've been doing in the last fraction of a millisecond in the total existence of the human race. We've changed our lifestyle so much, modern man has, but our genetics and our physiology has lagged behind. We were supposed to use fasting and feasting as part of our normal program, as our normal physiology. That's why we still have it. That is why after 12 hours, you start making some more ketones in your body. The ketones come from fat. You're moving that fat out of storage.
What is a ketone?
Ketones. So ketones are a energy molecule produced by the liver. How does it make it? It makes it from fat. So the fat gets liberalized, and by the way, the fats only start moving when your insulin levels are down. So because of fasting, your insulin levels are really low now, okay? Because you've been fasting, right? So now the fats start dissolving. So you get free fatty acids. The free fatty acids float into the bloodstream. Free fatty acids are fat products. They float into the bloodstream, they go to your liver. Your liver converts those into ketones. Now, ketones are an energy source of the body, an alternative source to glucose. So in general terms, you are either going to be running on glucose and glucose metabolism, or you're running on ketones. Okay?
And so ketones basically show up when glucose isn't around.
That's absolutely right. So ketones are actually a cleaner fuel for the body. And in terms of producing reactive oxygen species in the metabolism, the way your mitochondria work, you actually produce less reactive oxygen species, which is damaging to your physiology when you're in ketones. And ketones are signaling molecules that also change your physiology in a number of ways. Number one, it causes the production of brain-derived neurotropic factor that occurs under ketogenesis. Brain-derived neurotropic factor, which means that you become smarter, you're growing new cells, your reflexes are better, your visual acuity is better. Why? Because nature wants you to become a better specimen so you can go out and get your next kill.
So why don't we all just stay in a state of ketosis then, if it's so miraculous?
Well, that's a great question. You don't want to be in ketosis all the time, because that's not what ketosis, what our physiology was made for. Because then you'll just be burning fats all the time, and that's not a good state to be in constantly either. So you want to be able to do both. You're supposed to get your current account and your deposit account. You're supposed to work with both of them. That's the normal physiology. So not only brain-derived neurotropic factor increases, but also stem cells. Stem cells are amazing. And in my patients, of course, I see that.
What is a stem cell?
Stem cells. So stem cells are, we all have stem cells. And we all still make stem cells. And they're produced by the bone marrow. These are pluripotent cells. Cells made that will then go out and become whatever they need to become. So they can go out into your circulation, become a muscle cell, they can